Welcome, everybody. My name's Andrea. I am with Metro Council. I actually work for University Health, Behavioral Health, and we are part of the Metro Council. That is the Metropolitan Council of Community Mental Health Centers. And the Metro Council is a collaborative membership organization representing the public mental health system of community behavioral health centers in the greater metropolitan Kansas City area. We provide support to our member organizations and education, information, and resources to the public on accessing quality health services. We host the Mental Health KC Conference every May, as well as provide free webinars on the second and fourth Thursday of every month. You can register now for our upcoming fall symposium, which is next Tuesday, October 28th from 9:30 to 12:45. The topic is Posts, Privacy, and Professionalism, Ethics in the Social Media Era, presented by Chris Brown. And that will be taking place at the Redbridge branch of the Mid-Continent Public Library. And it's only $25 for 3 pre-approved CEUs, and it's ethics training. So if you're looking for that, we do still have a few spaces available. It is going fast. So I recommend if you are interested in joining us for that, that you go ahead and get registered like ASAP. I just put the link in the chat and we'd be really happy to have you there. We're excited for a great turnout for that. Also, our 2026 Mental Health KC Conference speaker proposal is officially out. We're looking for dynamic speakers, panels, and posters. We'd love to have new ideas, variety of things, so please submit your proposal. The link for those I am also going to put in the chat, and you can find this also on the Mental Health KC website. Just a reminder today for this webinar and any educational events that Metro Council puts on, the views and opinions presented are those of the speaker and do not necessarily represent the opinions of Metro Council. At the end of today's webinar, I will put the link and the password to get the certificate of attendance for this webinar. That is the only way that you can get the certificate of attendance. So please stay till the end and I will drop that in the chat. All right, I am really excited to introduce to you today our speaker, Meghan Kanya, who is presenting on identifying and treating depression and anxiety in today's world. Meghan is a licensed psychologist at Phoenix Children's Hospital in Phoenix, Arizona. Dr. Kanya has always found passion and meaning in empowering and amplifying underrepresented voices and experience and breaking down barriers regardless of the context. While at Children's Mercy in Kansas City, Dr. Kanya's work focused on supporting the development of the depression and anxiety in youth clinic, or the day clinic, and working with preteens and teens with anxiety and depression. Her current clinical and scholarly work focuses on the intersection of social drivers of health and mental health, including promoting and maintaining strong ties to community engagement and advocacy work. Within Dr. Kanya's current role at Phoenix Children's, she is supporting the integration of psychology into primary care settings and further development of behavioral health resources for community members. And with that, I will turn it over to Meghan.
Thank you so much, Andrea. And hello to everyone watching. Okay, I'm going to go ahead and share my screen. So as Andrea said, I am coming to you live from Phoenix, Arizona. So I'm a couple of time zones behind you guys. It's still morning here. I know you guys are entering the afternoon in Central Time Zone. I was formerly in Kansas City. I actually only moved out to Phoenix about 6 months ago, and was in Kansas City for about 3.5 years, primarily working at Children's Mercy, mixing up my children's hospitals. My experience, I very much identify as a generalist. So in making this presentation, I hope that it is applicable to all of you who are working with all ages. We will talk a little bit about just developmental stages, or differences that you may see with different developmental stages and age groups. But really this presentation is meant to be applicable to any client that you guys are working with who may present with anxiety or depression in today's world. So throughout our presentation, we're going to go over the objectives, which you guys saw in the webinar promotional information, but we'll kind of separate the presentation into these 3 broad categories. So to start, we're going to talk about diagnosing depression and anxiety again in different individuals. So in general, again, I assume at this point that all of you have access to our DSM-5 or can access it by Google, since Google is also one of our experts at this point. And so you guys can look up the specific criteria for each of these DSM-5 depressive disorders. But in general, all of our depression-related disorders are going to really have themes of a presence of sadness, emptiness, or irritability. Typically, in kids and even our teenagers, we're seeing a lot more of that irritability. So, common complaints from caregivers who are bringing kids in might be irritability, it might be oppositional behavior or defiance. All of a sudden, they go from being a really easygoing kid to all of a sudden they are arguing, they're talking back, they're refusing to do schoolwork. There may be a lot of school avoidance or refusal. They may have stopped doing chores. They may be having trouble getting out of bed. A lot of that also goes with the anhedonia. So, again, that lack of interest in things, but also a lack of motivation, right? A lack of energy to actually get up and do things. In adults, we typically see more of that sad or emptiness, kind of blue moods, feeling under the weather. I think across to both teens and adults, one of the presentations that I've seen more commonly, or more and more, is a predominant anhedonia. So more of that just numbness, where we're not really feeling anything, not even sadness. And we'll talk later in the presentation about how that may change our intervention with those individuals. In addition to those two kind of primary presentation elements of sad or down, numb mood, and then the anhedonia, we're also looking for different somatic or physical changes. So changes in sleep, changes in eating, again, changes in energy. We're also looking for cognitive changes. And typically these are a lot more of a negative outlook on life, negative outlook towards themselves. So negative self-esteem, thoughts about hurting themselves, thoughts about ending their lives, feeling worthless, feeling guilty for all the things that we're not doing. And of course, all of that is negatively impacting our functionality, ability to do daily life skills, to interact with other people, to go to school and work. Um, all the different depressive diagnoses are going to be distinguished by how long the depressive state has lasted, the intensity of it, the timing of it. So, particularly with premenstrual dysphoric disorder, we're really looking for the timing alongside of the menstrual cycle for the individual to see if there's any patterns and when we're seeing more of those depressive symptoms popping up. We also look for presumed etiology as well. We want to check to make sure that this isn't just a normal grief response that we're experiencing to something tragic that has happened to this individual. When it comes to diagnosing and even tracking how depression and depressive symptoms are changing throughout treatment, there are a lot of different questionnaires out there that you may use. Some of the ones that I have listed here are free to use. So, for example, the PHQ or the Patient Health Questionnaire is a free one. It's online. There's even like online calculators that you can use. MedCalc is a great one. And then there are some that you have to pay for. So the CDI or the Children's Depressive Inventory is a paid one that you have to buy those protocols. Similarly, uh, the the CBCL and the BASC are also paid ones. The DOS, if you are unfamiliar with that, is a 21 question, again, free online resource. It has scales for both depression, anxiety, and stress overall. It's meant for adults, but can be a good kind of global screening for how an individual is feeling or doing. For these questionnaires, again, with adults, we're primarily going to be doing self-report measures. So um, again, a questionnaire could also be a clinical interview, especially with how well we now all do with assessing some of these symptoms. For some of the child measures, they may also be parent report or teacher report, right? Trying to see, are there other things that the individual themselves, either due to developmental level or due to insight, may not be aware of. Tanya, I am happy to share my presentation afterwards. In addition to questionnaire measures, I also really enjoy using performance measures or having individuals really demonstrate like how they're interacting with life. And so ways to do this are using more of our projective or personality type measures. Again, this might be a little bit more of an in-depth kind of assessment of where someone's at in their state, but can sometimes be really informational, especially I think again for kids who may not be able to articulate as well as we want them to, what they're feeling and what they're experiencing. So projective drawings are a great way to do this again, especially with young kids. On this slide, I actually have two projective drawings that I often do with both my assessment kiddos as well as my therapy kiddos at some point during treatment. The first is a person in the rain. And so that's the one on the left. And this was a child who I ended up diagnosing with depression. As you can see, their individual is in the brain in the rain. There is nothing protecting them from the rain. And in fact, everything is just very doom and gloomy in this picture. The other projective drawing that I have is the house picture. So the prompt is just, can you draw me a picture of a house? One of the things that we like to really look out for with the houses, especially when we're trying to assess for things like depression, are warmth within the home environment, which is indicated by chimneys or smoke coming out of the house. And so here, there is no chimney. And so this was drawn by a teenager who actually had really low social support, particularly within their family. They felt very much like an outsider. They felt very distant from their family, felt very misunderstood. And again, you can see that represented in their house within that theme. An additional piece to this house too is that although they drew a door, which again theoretically is an opening to themselves, right, to connection to relationships, there's no way to get to the door right now. So they have neglected to make a sidewalk or stairs or anything else. And so it's almost this facade of being social, right, of wanting social interaction, but also a guardedness, right? A sense of I want you, but I don't know how to, or I'm scared of what that might look like, which again could indicate that social isolation piece that can sometimes present with depression. There are also incomplete sentence prompts that you can use. Again, there's a lot of free ones that you can find on the internet. And then, of course, we have our personality batteries or questionnaires like the mask, the PAI. I'm sorry, not the mask, the Mackey PAI, or the MMPI, which can always give us some more information broadly about how they are interacting with their world and space. Switching to anxiety, again, similarly, there are a lot of DSM-5 diagnoses for anxiety. They're all going to be, again, thematically really focused on an excessive anxiety or worry compared to the stimulus. And I put excessive here in quotations because it is subjective, right? It's excessive to the individual, right? They maybe feel out of control within that anxiety, or it may be excessive to individuals who are experiencing the anxiety. So if you ask the individual if they feel like their anxiety is appropriate given this feared stimulus, they might say, absolutely, this thing is super dangerous. I've been hurt by it before. But everyone around them may be able to acknowledge, actually, like you have a really big reaction to this thing that probably isn't as maybe threatening as what you're interpreting it as, and that's leading to a lot of functionality challenges. And so we want to try to really get an understanding of how excessive, right? How big is the reaction compared to the stimulus? And is this typical or is this something that is out of proportion compared to what we would typically see? Again, within anxiety disorders, we're going to look for somatic or physical changes. Oftentimes, these are somatic or physical changes in the moment when the anxiety is experienced and are very much related to that autonomic fight, flight, freeze, or fawn response. So again, we might see changes in heart rate, in breathing, digestion. There might be cognitive changes as well. So having our brains go completely blank or having a rush of thoughts and impulses as well. Typically with anxiety disorders, we see avoidance of the stimulus entirely. So we're completely avoiding the feared stimulus or we're enduring whatever it is with distress. So in the moment are panicking internally, but doing it anyway. And then, as I mentioned, a lot of these diagnoses are going to be distinguished by whatever the feared stimulus is. So for separation anxiety, the feared stimulus is being separated from loved ones or from a safe space. For social anxiety disorder, the feared stimulus is talking in public, performing in public, or social interactions more specifically, and then the judgment or embarrassment that might come with it. Similar to with depression, with young kids and teenagers, we're typically going to see anxiety presenting a little bit more like irritability, which again can lead to those oppositional or defiant presentations. And so when you have a kiddo or a teenager whose caregivers are bringing them in specifically for defiance or opposition, I would highly recommend that we are screening them for anxiety and depression, as we know that that might be underlying some of those behaviors. Additionally, with anxiety, we often see this presenting physically first. And so oftentimes I will get kids and teenagers coming into my office complaining about stomach aches or complaining about headaches. And that will often lead me to screen for anxiety, which is often there as well. And so making sure that we're doing our due diligence in screening for both. A lot of times by adulthood, individuals are able to acknowledge that there is some nervousness, there is some fear, there is some worry that often comes up. Again, adults tend to be a little bit more aware of those internal sensations and the thoughts that might come with them. One thing that I always try to note with anxiety is that anxiety is a normal human emotion. Our goal in treatment and even our goal in assessing it is never to call anxiety bad or negative or even to try to get rid of anxiety completely. That should never be the goal. Anxiety is meant to keep us safe. That is why evolutionarily we still experience anxiety. There are still things that within our anxiety system or within that warning system that are effective and help motivate us, right? Help keep us going in the world. Anxiety disorders are having a faulty alarm system, an overreactive alarm system. And so framing it like that can be very helpful, I think, especially for older patients. When it comes to diagnosing anxiety, again, we have a lot of different questionnaire measures. There's actually a lot more for kids than there are for adults. Similar to depression, some of these ones that I have listed here are free, and then some are ones that you would have to pay for by protocol. The other thing, again, similar to depression, is a lot of our adult measures are going to be self-report, and then the child measures can be a mixture of child, parent, and then sometimes an other report as well. Just like with depression, we can also use some performance measures to help diagnose anxiety or help to help identify it. Here again, the picture on the left is another picture of a person in the rain. And again, this time we have a person who is standing in the rain. They do have things that should be keeping them nice and dry. So they have an umbrella, they have a raincoat, they have rain boots. However, everything in their world is still getting them wet. So their umbrella doesn't work. Their rain hat doesn't work, their raincoat doesn't work, and they even have a car that's spraying water up and into their rain boots. And so they are feeling overwhelmed by the amount of stress, the amount of chaos that's in their life, and are judging themselves as having really poor coping to deal with that. On the right is a picture of just a person. So the prompt for this one is just draw your best person. The individual who drew this was a really thin teenage boy who had a lot of social anxiety about his physical stature. He was one of the smaller kids in his grade and was often bullied. And so again, within drawing just a novel person, this was the image that came out. A very big, bulky, muscle-focused individual. One of the things we look for in these drawings is also facial features. So the eyes being really big suggests some hypervigilance, some kind of constant awareness or need to watch out for all these different things. So again, this can be a really helpful type of drawing to do with young kids, teenagers, even adults, to help understand a little bit more about what's going on for them and how they're really interacting with themselves and other people. Okay, so switching gears. After we have diagnosed either depression or anxiety, then we can shift to treatment. Within treating depression and anxiety, there are a lot of different theoretical orientations out there and modalities. At this point in time, some of the major ones out there are CBT, so cognitive behavioral therapy, acceptance and commitment therapy or ACT, dialectical behavioral therapy, DBT, and then we still have a pretty strong collection of psychoanalytic or psychodynamic related therapists. And so within psychotherapy, kind of bridging all different theoretical orientations and modalities, the things that we're really going to focus on to treat these conditions are going to be lifestyle changes. So really kind of focusing on behavioral choice, using exposure therapy when indicated for anxiety, using behavioral activation when indicated for depression, really managing our sleep, our eating, our social media and technology use, but also engaging in some relaxation training as well. So teaching diaphragmatic breathing, teaching progressive muscle relaxation, teaching just kind of how to re-experience our bodies in maybe a new and safe way. We also are going to engage in some thought work. So oftentimes, especially with kind of school age kids and up, we're going to be able to do more of this cognitive processing, which can include challenging, especially if you're more of a CBT oriented provider. It can also include accepting and diffusing if you're more a third wave CBT provider, so ACT and DBT. And there's kind of another type too, which is kind of just processing. So being able to really think and explore what those thoughts mean, which may be some of our more process-oriented orientations. In addition to that, we're going to do a lot of emotion work. So we're going to try to reduce shame, particularly for depression and anxiety, because these can present in really public ways or really social ways that then lead to a lot of shame and guilt. In addition, we're going to try to promote pleasantness or pleasant feelings, and then really promote emotion regulation as well. Relationally, we're going to work on communication. We're going to work on attachment and making sure that our patients know what a safe relationship is, what a healthy relationship feels like, really helping them understand what it feels like to be vulnerable in a safe way, and how to do that intentionally. We also may engage in some social skills training. So, for example, some of our kids with social anxiety disorder or selective mutism may need some additional skill training to be able to up some of those social skills depending on kind of where they're at. Finally, we're also likely going to include some mindfulness where we learn how to hold space for our emotions, for our thoughts, for our bodily experiences, but then also building distress tolerance. And we'll talk more about kind of distress tolerance later on. But just the idea that for a lot of people, again, both depression and anxiety are really distressing feelings. And there is an urge to immediately want to push them away, which then leads to automatically to suppression and avoidance. Instead, really what we want to try to coach our patients to do is to learn how to hold that distress, learn how to feel anxious, learn how to feel sadness and anger and shame and guilt without running from them, right? To feel them appropriately and in a manageable way. In addition to psychotherapy, there are medications out there to treat both of these different conditions. Again, these are pretty common conditions at this point in our country, and so we have a lot of medication options. Partnering with a medical provider is very much indicated here. There's a lot of research to suggest that the partnership of both psychotherapy and medication is our best way to move through treatment. There are a couple of newer treatments as well that are out there. So we have ketamine-assisted therapy where individuals are prescribed and given some ketamine ahead of some therapy sessions where they're able to unlock different parts of themselves within that experience. There's also transcranial magnetic stimulation or TMS, which has been shown to be really helpful for treatment-resistant depression, especially in the FDA just approved it in teenagers, and so teens kind of and up. And then there's deep brain stimulation, which is a more invasive implant where we're similarly to TMS using electromagnetic stimulation to help activate areas of the brain. So I wanted to focus in on two, again, specific areas, one of depression, one of anxiety that, again, in my work, I've seen popping up a lot more often. With depression, as I kind of alluded to earlier, there's this primary anhedonia presentation that feels more and more common to me, where again, people aren't coming in expressing sadness, expressing feeling down. They're expressing feeling nothing. They're expressing just being blank and not feeling much of anything. And I think that that can be a really hard one to engage with, because that flat affect, that blunted affect, it often is accompanied by really low motivation for change. And so, again, there's been some research that has suggested that this primary anhedonia presentation is related to poor outcomes. So, it is a more treatment resistant presentation. And part of that is because there's, again, this patient focus on decreasing negative affect. So again, wanting not to feel negative, right? Wanting to avoid feeling sad, wanting to avoid feeling irritable, wanting to avoid feeling down. But when we suppress one emotion or one emotional experience, we suppress all of them, including all the good stuff. And so sometimes that is a challenge within treatment where, again, like that's where that distress tolerance comes in, where we have to support our patient in being willing to experience both sides of the coin, the comfortable or the pleasant with the uncomfortable or the unpleasant. In addition, sometimes for these individuals, what is triggering that anhedonia or that numbness is also a fear of happiness and hope. So if individuals have had a lot of disappointment in their lives, if they've had a lot of struggle, if they've had a lot of barriers, it can feel scary to have hope. It can feel scary to feel happy because one, that might mean that they're not depressed and that's a whole new identity for them. But two, it may also mean that if they feel happy, then there's a potential loss of happiness. And that loss of happiness sometimes feels scarier, feels harder to manage than just not feeling happy at all. And so really trying to explore with your patient first, what side of this are they on, right? Like how do they approach their less desirable feelings? Is it, I'm okay with feeling them, but more it's the positive that I'm trying to avoid or I'm scared of? Or is it that there's this intolerance or intolerance of negative experiences? There is a wonderful treatments that workbook for positive affect treatment, which is specifically kind of tailored for this primary anhedonia presentation. And really, the recommendations are similar to, I think, ACT, where we're going to be engaging in meaningful activities, so value-driven activities. Attending to the positive, so trying to use some of that gratitude work, trying to really make sure that we are focusing on ordinary moments of peace and happiness, and then trying to build more positivity in life. So a lot of times that's met with community connection, but also some of that behavioral activation. So trying to find what hobbies do we want to engage in. There is a really fantastic YouTube video, which we will not be able to show today because we don't have sound, but I will make sure that you guys can have the link to it. It's a really wonderful video on mindfulness, but presented in a way that talks about mindfulness being the gateway to ordinary happiness. The idea being that we have opportunities in every single day we live to find ordinary happiness. Ordinary happiness isn't the happiness that we see in movies, that we read about sometimes in books. It's not big. It's it's small moments. It's taking that first sip of coffee when you're really exhausted in the morning. It's watching the sunset and taking a big sigh as you watch the colors paint the sky. It's acknowledging and holding space for when you have a really connecting moment with another individual. These moments happen every single day. And within that, there's a lot of research to suggest that happiness isn't this external event that we have to wait for, that happiness is an internal choice, right? That if we are able to choose, right, to focus on these small moments of happiness, these ordinary things, then that will lead to more and more of them, right? Like we all know how brain priming works, right? And how brain conditioning works. We can train our brains to look out for these things. And within that, create a state of happiness that is different, that leads to more, again, like peace and contentment. Um, One of the things that Mike talks about in his video is that there's research that has been done that adults spend 50% of their lives distracted. And when we only have one life to live, that is a huge amount of time that we're spending distracted. And this research was done before social media, before phones were really big. And so the things that we were being distracted by aren't phones, which I think is oftentimes people's first go-to at this point in our world. Instead, the things that we're distracted by, they're taking us out of the present moment, are our thoughts, right? And specifically, thinking about how we want to be feeling, right? Thinking about what we want to be thinking, thinking about what we want to be doing, thinking about the happiness that we're going to have in the future once we accomplish this thing that's going to lead to the happiness. And if we just spent more time being in the moment, right? Acknowledging the happiness that we have right now, or not even the happiness, right? The experiences that we're having right now, it would likely lead to more experiences, more humanness, right? And so, like I said, I think he does a really nice job presenting this information. He also has a wonderful accent that helps too, but his voice is very soothing and kind of goes along with it. So I recommend it. And like I said, his video I think goes along really well with the treatment recommendations for primary anhedonia. His video is often one that I will share with patients that I'm treating for this condition. And I'll talk to them about the newer concept of glimmers. So for those of you who aren't familiar with the idea of glimmers, glimmers are the opposite of triggers. So just like triggers, or stimuli or experiences that trigger our automatic or autonomic nervous system's fight, flight, or freeze response. Glimmers are going to be, again, just novel events that are happening, stimuli that, when focused on, will create resilience within our nervous system. It really promotes that rest and digest. It really promotes well-being. And so it can be a really nice way to kind of thread some of these concepts together. And then I think, as a lot of us know, um, doing value-driven activities, right, or engaging in behavioral activation is going to be way more powerful when we're paying attention to it, right? When we're being mindful doing it versus just kind of going through the steps. The other kind of call out that I wanted to make is, I think in today's world, there is a lot more anxiety that would likely be coded as generalized anxiety, right? Our world right now is a world of uncertainty, and it's a world where learned helplessness is a very real state and very common. And so treating anxiety, particularly political stress or political anxiety, I think is one, especially if we're working with adults or teenagers, is one that's becoming more and more common for us to help to try to manage within our sessions. With treating political anxiety, what we want to do is acknowledge the reality, right? We want to not necessarily jump into our CBT skills of denying the reality of the situation, but we want to really hear from our patients, like, what is scary about what's happening right now, and how is it affecting you, right? And we want to sit with them in what is reality to them. Um, we also want to try to support their management of time, obviously engaging with content, but also engaging with the anxiety. So again, just like our regular anxiety skills or anxiety treatment, we might try to help them schedule a time to be anxious, right? Or schedule a person to be anxious with. We want to help support them in understanding critical thinking and finding reliable sources to follow, or ones that, again, don't lead to that increased anxiety. One of the things that can be really helpful, especially for patients that are expressing not only that political anxiety, but also kind of some helplessness in, I want to do something, but I don't know what to do, is to help them figure out, like, what is their niche or their space within what's currently happening within our current world events. And there's been some research done within kind of social justice work, as well as kind of more like historical and social psychology work, about kind of different areas or roles that people fall into when there are world events and national events like we're currently seeing. And so Some of these might be, right? Like we might have individuals who identify as fighters or healers or caretakers, people who are builders, right? Who are imagining a different future, people who are really good at public speaking and engagement and maybe are going to be able to be the political actors, right? Be the new politicians. That helping our patients find what is their role versus having them feel like everything is their role, right? Maybe they're not the person that's going to go to protest, and maybe that's okay, right? Maybe they're not the person that's going to post on social media, and maybe that's okay. But maybe there is a role for them or a space where they feel like they're able to contribute, they're able to have some control, and being able to really support them in identifying it, typically based off of values and skills, and resources, but also be able to engage in it. And then, of course, like really helping them focus locally is going to be really helpful. On the national or even international level, there is very little that we as individuals can do. And so instead, really helping them focus on local events, local organizations, local community, and starting there and seeing what difference they can make even in a small space or smaller space. Again, whenever we have big events like are currently happening in our world, in our country, there is a lot of grief, there's a lot of frustration, there's a lot of anxiety, and within that, it can sometimes feel wrong to experience joy. But again, as I was mentioning before with anhedonia, joy is such an important part of this, right? We have to always be able to experience both things. And joy is part of what keeps us going, right? It's part of what keeps us moving forward and being willing to confront our anxiety, being willing to press on those things that feel under attack that are really important to us. And so, really encouraging our patients and making sure that they are like finding time to do things that they enjoy. Obviously, routines are really helpful, especially like like hygiene related routines, right? Going and doing these things in community, but also showing up to work, going to school, right? Doing the mundane as well as the spectacular. And then grounding and mindfulness is always helpful. Okay, so I want to flip gears for these last like 10 minutes or so, um, and think a little bit about again the world and the country and again states that we currently live in. I spent some time just grabbing some headlines, and these headlines are all pretty much from the last year. And I was struck myself by just, you know, how much we as mental health providers are being tasked with right now. We have children and teens who are needing more and more. There is a mental health epidemic happening with our youth. We see rural America and their resourcing continuing to be lacking, but also continuing to be diminished, especially with potential funding cuts that are coming. We see parents experiencing heavy, heavy loads of distress and stress and anxiety and depression because of the monumental task in front of them and the lack of support that they're often given. We see that a lot of Americans at this point, with somewhat decreased mental health stigma, are wanting to talk about it, but maybe don't have spaces to talk about it or don't have medical providers who feel competent or comfortable talking about it. And so this all results in a whole lot of anxiety and depression and stress and nowhere to find support. This is also reflected in our research. So again, from research from the last 4 or so years, we see that anxiety and depression has increased in adults. We see that it has increased in our teenagers. We see that even teenagers say that it's increased in their peers, that they can see it in the other kids that they're going to school with. We know that climate anxiety is a whole new area of anxiety that we now have. And that we are, again, as mental health providers, tasked with helping support our patients through. Similarly, we know that political concerns and anxiety has increased significantly over the last several years. And then we know that, particularly in the last year or so, that even within our workplaces aren't safe from anxiety and depression any longer. That there is stress And there is distress in almost every single space that we occupy. And that's really hard. And that is not going to be cured by CBT. And it may not be cured by any of the theoretical orientations that have existed up until this point that we have all been trained in. That what is currently happening is so new to our relatively new mental health field, right? I mean, like mental health as a field has really only been in existence for maybe a century, right? That that we are currently in an experiencing a new frontier in mental health and mental illness. And with that, we might have to get creative in how we're approaching it. That some of the old techniques that have been, right, evidence-based and really, really helpful may no longer be as helpful, as beneficial. And so I think like when I sit in this for myself and I sit in, again, like what my patients are experiencing, what their families are experiencing, what my community is experiencing, I often I try to reflect on some of these pieces. So much of our field, because of a lot of things outside of our field, are dictated by diagnoses, right? That even to really be able to treat a patient and get reimbursement for it, our patients have to have a diagnosis. But what if what they're experiencing is very normal given what's happening? That there's nothing irrational or illogical about what they're thinking, what they're feeling. However, it's negatively impacting their functioning. Within our current healthcare system, that still requires a diagnosis, even though, again, like they may not be disordered, right? Like their experience may be a result of context, right? A result of systems that they're not in control of. And so trying to really think about how we're approaching diagnosis at this point and how we're even talking about it with the patients that are sitting across from us in the room and potentially being transparent with them, right? Like, hey, I'm going to be giving you a diagnosis of, right, like generalized anxiety, right? And here's the reason why. And, like, here's where it might not totally fit with you, but, right, like, this is how we're going to progress. And this is what it's going to mean moving forward. Helping them, right, like, understand themselves and understand how they identify with this diagnosis in a way that's going to be productive for them within the current context that we're living in. Again, we really as a field like need to continue to come back to how do we sit with normal dysregulation at this time and how can we be promoting it on a public health framework, right? If we're seeing the majority of our patients coming in with again mental health concerns that aren't diagnosable, right? Like we might have to, as a field, lean further into public health and health literacy and be able to really promote in a public space what it means to do distress tolerance, right? Starting from our itty bitties all the way up to our geriatric populations, that this may have to be a skill that is really focused on and prioritized and talked about in a way that maybe it hasn't had to be before. In addition, I think a lot about the idea of hope. I think within our field, a lot of why we do this work is because we all see potential in people, right? Not only do we want to help people feel better, but we see the potential, right? We have hope for where they can get to, for how they can reclaim their lives or reclaim who they are. And sometimes our hope can come across as blind optimism, right? And sometimes our that optimism can be harmful, especially if what we're promoting to our patients or to our clients is hope without direction, right? Hope that is maybe again hope in a fantasy land versus a realistic driven entity. Hope is a skill, right? Hope is an emotion, but hope is also a skill. It is a concept. And there are ways to cultivate hope in a productive way without it being blind optimism. And that's really the space that we want to make sure that we're existing in as well, is hope has to have a path forward versus blind optimism is just, you know, blind faith, believing that things will just eventually work out, which may not be the case for everyone that we're working with. Again, we also want to come back to what is the goal of therapy? I think again, going back to traditional CBT, right? Traditional orientations, a lot of times our outcome or our goal was decreased symptomology, right? Or return to functioning, or again, just changes in thought, right? Changes in behavior. At this point in time, right, the goals for treatment may be different. It may just be adapting, right? It may be supporting our patients surviving this moment. And while none of us love to write that into a treatment plan, right, is like the goal is survival, maybe that is the goal. With the caveat that that survival goal is temporary, right? Because of this context, because of this thing that we're all experiencing collectively together that we might not be able to have a ton of control in right now. And so again, like we might have to kind of piecemeal together, what does adaptive coping look like right now in the current state? And then we'll figure out what it looks like in 6 months when everything changes again, or a month when everything changes again. Finally, again, I think a lot of traditional therapy has really focused on the individual, right? Our focus as a field has really been on individual treatment. There has been newer research that's come out recently that has shown that group therapy can just be just as effective as individual therapy. And part of that comes back to community and the focus on and the need for humans to be in community with one another. Humans are social beings. Done. Period. We feel physical pain when we're isolated from other people, right? That's why some of our harshest punishments that we use on humans are isolation, right? We use timeout on kids. We use detention on teenagers. We use solitary confinement on adults who are in jail and prisons. It physically and mentally hurts us to be alone in isolation. At this point in time, especially given the profound levels of helplessness and hopelessness that a lot of us may be feeling on a day-to-day basis or weekly basis, the focus has to be getting back to community. The focus has to be returning to our innate socialness, that is most of the way forward for us, or at least it should be. So then when we think about, right, how some of these things may affect our therapy, right, or affect our approach, there's an acknowledgement that we as mental health providers may need to do some re-education for ourselves. We might need to learn new and different strategies, given that what we learned in grad school or what we have learned in our CEs so far maybe isn't cutting it anymore. And so I think like where to start is sometimes just learning about history, learning about how we got to this point. And not only again as a state, a country, a world, but also as a field. That again, I think the more that we understand some of the hurts, and even some of the choices that we as a field of psychology, right, or mental health more broadly have made to be able to demonstrate our need, right, and our purpose, and be able to delineate ourselves from other professions, we can start to maybe poke some holes in why it might not continue to work moving forward. That again, like there likely needs to be some philosophical field changes in how we're thinking about these and how we're approaching these things. Similar to what I was talking about earlier, we know that our DSM is flawed, right? We do. That's part of why we're on our fifth plus revision of it, right? Is that as we continue learning about humans and human behavior, right, we come up with different names for things, different conditions, different etiologies. And one of the things that we want to try to keep coming back to is, again, being skeptical of some of those diagnoses that are really identity based. So I think of, for example, ODD being a huge disorder that is diagnosed in boys of color. That the rates of diagnosis are really high compared to boys who aren't of color. And that maybe there's a bias there, right? Maybe there is something systemically or societally that leads to some of that bias. I also think of a disorder like borderline personality disorder, which is predominantly diagnosed in women. When there's more and more research coming out, right, that a lot of those female individuals or female identifying individuals have had trauma. And maybe that's why they've developed the personality traits or the ways of reacting to the world in the way that they have. And so, again, like I say all that to really make the point that our field is really young. And I said that before, but it is. Our field is really young and we still have a lot of learning to do. Although we have, I think, some really strong evidence for what we have been doing and what we are doing currently, there will undoubtedly be changes that come in the future as more research is done and as the world continues to change. And so a lot of this too is continuing to educate ourselves and continuing to be flexible on how we really support our patients and how we really support our communities at large and humans. The more that we can also just dip into trauma-informed practices, regardless of the orientation that you're using, the more helpful it's going to be for all patients. Even patients who haven't been exposed to trauma, who don't have PTSD, benefit from trauma-informed practices. And so the more that you can lean on those, the better you're going to be serving your patients. Again, we really want to be aware of how we are existing in the room. Again, there's been a lot of teachings in the past about, like that as therapists, right, we're the experts and we come in maybe with a blank slate, depending on your theoretical orientation, that you are a teacher, right? You're a coach, you are a scientist. And all of those roles also have biases. All of those roles exist not in a vacuum. And so being aware of how, again, your personal identity, your assumptions, your lived experiences may be influencing you as a scientist, you as a coach, you as a teacher, you as an expert, and just being aware of them, right? So you don't need to change them, but you should be aware of them so that if you need to change them, you can. You have the ability and awareness and the insight. And then again, I like to point out that therapy is political. This has come up a lot, especially in the last year, but our field has, for a really long time, been dedicated to holistic healing of all humans and really appreciating the humanness in individuals. And we also know that, like a lot of our jobs are dependent on federal funding, right? Whether we are scientists, right, and doing grant-led work, or we're looking for reimbursement from insurance companies and Medicaid and Medicare, that even if our work in the room isn't political, right, even if we're not talking about politics with our patients, our roles exist within policy, right? They do. Like policies affect almost every single thing that we do as therapists, as mental health providers. And so if we're not involved in politics, right, if we're not aware of what's happening, we're doing ourselves a disservice as well as our patients and the community. And finally, we really, again, in this space that we're in now, we want to be really looking for opportunities to build community and collaborations. So that could be collaborations in community with medical providers who are seeing similar patients as you and trying to help support patients in new and novel ways. It could be, as I said before, group therapy, really, right? Leaning on support groups, leaning on process groups, leaning on psychoeducational groups, or webinars that hundreds of people can attend at a time or go back and watch. That we're at a time in our field where we're having to get more and more creative about how we get this information out to people in need because there aren't enough of us. And even if there were enough of us, our healthcare system is not efficient enough to allow all those people to be seen by us. And so we have to get creative. And a lot of that, again, is going to be leaning on community and trying to form collaborations, trying to find collectives who are supporting patients and communities. Again, we really want to support our patients in building their cognitive flexibility and their distress tolerance. Those two skills alone are going to go so far in today's world, and will encourage so much resilience and positivity for individuals. And then again, like we also want to, the last point there is really making sure that we're also taking care of ourselves with the acknowledgement that we are also existing in the same world, same country, same state that our patients are. And we may be just as affected by everything that's going on. And so making sure that we're also using our tools to support ourselves within everything that's going on. Um, and so with that, I'm going to go ahead and pause and say thank you for listening and see if there's any questions.
There
And I
are a
know,
couple things, Megan, that came up in the chat. And I saw the very latest one was about the certificate. So I'm going to go ahead and put that in the chat because I know people were 4 minutes from the end. So that certificate of attendance
uh-huh.
is in the chat. But one of the questions that came up kind of early on was about the drawings that you showed. Are there instructions for those somewhere? How do you get trained in order to be able to provide that type of assessment?
Yeah, so there are definitely trainings that you can do. I learned how to interpret and administer those measures on my internship, which was a more psychodynamic or psychoanalytic leaning site. But I can send the instructions along with my PowerPoint if you're interested, Joy. And then there are some different resources, I think, online as well for kind of how to interpret them broadly. Again, the thing that I always like to acknowledge with the drawings is that you're never just going to do a drawing, right? You're never going to make a diagnosis just based off of what someone's drawing is. It's going to be within the context of everything else and all the other data that you're collecting. And so, like I said, I'm happy to provide some resources for that, with the acknowledgement that yes, you will probably have to do some either independent led training or get some like CEUs for it.
But would the best way for people to get your slides and stuff like that is to email you directly?
Yep, feel free to email me. Feel free
And
to
I
email
see
me.
people are having trouble with the CEU certificate, so I will work on that here in just a second. Um, there was also a question about oppositional defiant disorder, and does that have to be diagnosed by testing? How do you determine if those behaviors are not attributed to a different diagnosis?
Yeah, so ODD does not have to be diagnosed by testing. ODD is a diagnosis that, and again, this is me speaking from my own preference, it's one that is a last resort diagnosis for me. Partly because ODD is a diagnosis that is attached to the child or the teenager, when really it's a diagnosis that is typically describing the context in which the child or adolescent is existing. So a lot of times we won't have ODD if we have cohesive and collaborative like parent-child relationships with really strong attachment. And so it does not have to be done by testing, but we're going to look for the behaviors. And again, some of the other testing that I will often do is doing an assessment of the family system, or of the other kind of context in which those behaviors may be existing. I would typically rule out, again, anxiety, depression, ADHD as well, or any neurodivergence, knowing that those often are also potential culprits for mismatches between parenting and what the child or the adolescent are needing, or even like teaching styles and what the patient is needing. And so just making sure that you're really doing a thorough assessment of other factors that may be leading to some of those behaviors.
One more question here. What about long COVID, and how much are some of the anhedonia and symptoms part of the psychiatric effects of COVID infection? It's a great,
That is a fascinating question,
yeah.
Michelle, and it's not one that I've thought of. So, I'm not sure it would be my answer. kind of most superficially. That said, I think that we do acknowledge that there is a lot about long COVID that we are still trying to understand, and still trying to figure out even what some of those, again, like effects from COVID, one infection, two infections, multiple infections are, and even like what are some of the biological factors that lead to some people experiencing long COVID versus being able to get over it really quickly. And so I think it's a really interesting question, and now I'm going to go have to research it, Michelle. So thank you.
Yeah,
Yes, light therapy is still considered effective for SAD, Connie. You can buy them on Amazon. But yes, it's a highly recommended one. I know a lot of our psychiatrists that we work with who treat depression will often recommend it for people.
fantastic. This is great information, Megan. Um, really appreciate your time today. Yes, thank you all for your comments in the chat. I realize as I'm working on the certificate that it's not working either. There was a widespread outage with some websites earlier this week, and I wonder if that might be impacting it. So, since you're logged in here to the webinar, we do have a record that you attended. So I will, whatever email address you use to register, I will see what I can figure out on the back end, and we'll communicate via the Zoom registration process on how you can get your certificate of attendance. So sorry about that technical difficulty. Um, Thank you again, Megan, for your amazing presentation today. It's so
Yeah.
much good information, and I appreciate your enthusiasm for exploring different ways
Mhm.
of approaching um, depression and anxiety in the world today, because it is a lot.
It
Um,
is. Yeah, I appreciate everyone for listening. Thank you for having me.
Yes, it was awesome. Just a reminder to everyone, it was recorded and will be available on the Metro Council YouTube page uh, in the near future, as soon as we get that processed and uploaded. And the next webinar will be, I believe, the second Thursday of November, from 12 to 1. We will be promoting that and sending out the registration for that also in the near future. So thank you, everyone, and have a
Yeah,
great
and I'll
rest of
type
the day.
my email here in the chat too, because
Oh,
I
thank you.
a comment about that. Cool.
Great. All right. Thanks so much, everyone.